Hello, everyone, and welcome to this topic on panoramic and extraoral radiography. The reason I've combined both of these topics here together is that essentially we use the same X ray machine for both the radiographs. I'm Dr. Lahari from the Department of Oral Medicine and Radiology, Penang International Dental College. The learning outcomes would be to illustrate the principle of panoramic radiography, list 5 advantages and disadvantages of panoramic radiography, list 4 types of skull radiographs and describe their application, detect gross pathology on panoramic and extraoral radiography, comprehend the interpretation of panoramic radiographs. So we will be looking at the panoramic radiographs first before we move on to extraoral radiography. So let's begin with what panoramic radiography is. The term panorama means a wide angle view of any physical space. So what you can see here is a wide view of a city, and the city happens to be Penang. So the term panoramic radiography is applied to the panoramic or the wide view of all the teeth together in one radiograph. So that is the biggest advantage of this radiograph. And the other term that was initially used is the orthopantomograph or OPG, which is still used and very commonly to refer to as the same panoramic radiograph. A little bit about how the panoramic radiograph came about into existence was when Dr. Y.B. Patero, who is considered the father of panoramic radiography, in 1946 described slit beam method and called it parabolography. Here you can see him trying to make the patient sit on what looks like a dental chair and rotating around the patient with the X-ray machine to get the entire arch of teeth. Also, around the same time, Dr. Numata from Japan was the first to take panoramic radiograph of teeth. He used long curved film placed lingually to teeth and X-ray source and rotated around the patient's head. So essentially, both of them had given out similar kind of principle, but you would have to actually place the film inside the mouth, and somebody had to hold the source and move around the patient. So from there on, the panoramic radiograph has come a long way. If you look at the evolution in 1952 to 1960, you see that it's still a chair with the X-ray machine and having to rotate around the patient, or probably a mechanism where the intraoral X-ray machine could probably rotate around the patient. But it's taken around 30 to 3 decades to 4 decades to actually come to this stage where we are, where we're using a digital panoramic machine. And this is still 2002, and we've evolved beyond that. So the extraoral imaging, it is a method of extraoral imaging, and essentially we use digital imaging. Now, panoramic radiography was film-based imaging, and most of the places we've done away with film-based imaging and moved on to digital imaging. So you still have the X-ray source, which I have pointed out in this picture here. You still have the digital sensor to capture the image. So you notice that the patient is in the center of the source and the sensor. Patient is wearing a protective lead apron, and that is a bite block on which the patient bites to stabilize himself in the center of the rotation. And you have software to view the image. So you need multiple things to actually bring about a panoramic image that you see on the screen there on the computer. Coming to the most important aspect, which is the principle of panoramic radiography. Now, in order to see the arch as a flattened structure, you must understand that in nature, actually our arch doesn't exactly exist like a flattened structure. It's a horseshoe-shaped or a semicircular structure. The jaws, the maxilla and the mandible I'm talking about. So it's important that if you want to look at it as a section, only that area which has the teeth, you would have to apply a principle called as tomography. Tomography means to body section radiography. You must be wondering, why is there a picture of a loaf of bread here? It's just to signify that what we mean by body section tomography is that if this entire loaf of bread is your head and neck region, the X-ray machine is able to slice out slices of bread and able to show you one particular slice clearly, which is the maxillofacial area or your dentofacial area of your dentition. So in order to do that, it's important that your dentition lies exactly in this imaginary line called as focal trough. We'll discuss more about this as we go ahead. So it is based on the principle of reciprocal movement of the X-ray source and the image receptor around a central point or plane in which the object of interest is located. So if your teeth, upper and lower, are located in one particular point of interest, or the area which I am talking about, the X-ray machine and the receptor are moving, let's say, in clockwise direction, reciprocally at the same time, capturing multiple images, and X-ray machine is shooting multiple X-rays and the receptor is capturing multiple images as it moves along the head. So essentially both the X-ray machine and the receptor move along the head of the patient while the patient is stationary. So there are some key terms that I would be using during this lecture. First of all is digital imaging. So you have understood it, that is, there you have a source and a digital sensor. Sensor is where you capture the image. I will be talking about tomography, which is body section radiography. Focal trough, it is a three-dimensional curved zone where the structures lying within this layer are reasonably well defined on the final panoramic image. The term superimposition, because there's going to be some overlap of structures which you see on the panoramic image. Ghost images, shadows of objects located between the X-ray source and center of rotation that get exposed twice. Now, all of these terms might seem overwhelming, but they are quite simple to understand. So let's look at focal trough again. Like I told you, it's a three-dimensional imaginary layer in which you want your patient's jaw to be positioned. So this is exactly a description of how that layer looks like, that three-dimensional layer. And when your patient's jaw is positioned at that point and you have taken into consideration the Frankfurt plane and the mid-sagittal plane, for which there are guidelines in the X-ray machine itself, you are going to get the best quality of images possible. So most of the time, the patient is, in all cases, the patient is stationary. So if you consider the jaw as a structure that is stationary, then for the X-ray machine to rotate around the patient and for the film or your sensor to rotate around the patient, you would require a center of rotation. So in earlier machines, there used to be one or two centers of rotations. But the imaging right now utilizes multiple centers of rotation along an curved area along which the X-ray machine and the receptor move about, and hence you're able to cover this horseshoe-shaped structure reasonably clearly. So that's what I'm talking about. The X-ray machine moves around the jaw. You have multiple centers of rotation along which the X-ray source moves and the image is captured. So it's a moving center of rotation. So this again helps you understand that the direction of the X-ray source around the patient and the direction of the receptor are actually either clockwise or anti-clockwise, and they move reciprocally together at the same speed. So if you were to look at modern panoramic machines, the shape of the image layer by using moving centers of rotation and by varying the relative receptor is able to capture multiple images and put them together. Let's look at this again. So it varies the position of the X-ray machine as well as the receptor to get the image. So the X-ray machine acquires the image in stages. You will see based on this picture here that it first covers one part of the jaw and then moves on to take multiple images to actually combine it and make the entire jaw look flattened. So the final image looks something like this. Your jaw is flattened out from one corner of the TMJ to the other corner of the TMJ, and you can see all four quadrants clearly in one image. So, just to look back at the focal trough again, is a three-dimensional curved zone where structures lying within this layer are reasonably well defined on the final panoramic image. I hope you must have understood what I'm talking about. So, what if the teeth don't lie within the image? What happens? So, this diagram's showing the vertical walls of the focal trough in the incisal region and the relative position of the teeth with different underlying dental and skeletal abnormalities. What we mean by that is picture A is if you have ideal occlusion and both your incisors are actually lying within the focal trough. What if you have proclined incisors? Or what if you have your, lower incisors set far away inside? So you would notice that these blue areas are the areas which get blurred or don't get covered. So the blue parts of the teeth lie outside the focal trough and will be blurred and out of focus in the final image. So that is what the importance of the focal trough is, which makes you understand that it's important that you manually make the patient position them within the area or the confines of the focal trough in the X-ray machine. Now, this is something which we can show you when we are actually showing you the X-ray machine and the positioning, and may be a little difficult for you to comprehend if you're listening to this lecture for the first time. Right, so like I told you, you need to ask the patient to bite on the bite block, and the jaw has to be positioned in the focal trough region. So, what happens when the position of the focal trough is exactly at the center? So, this is an experiment in White and Farrow, your radiology textbook, where they've used a metal ring in the center of the incisal area and imaged it, placing the jaw exactly in the center of the focal trough. You see that the ring is exactly rounded and has no distortion. But if the jaw is away from the focal trough, then you see horizontal magnification of this ring, and the teeth look broadened and fattened out. And if the jaw is positioned way too forward in the focal trough, you see that there is minimization or narrowing of the ring, and the teeth also become thinned out or narrowed out. So that is the critical importance of the focal trough and of patient positioning in a panoramic radiograph. Now we come to the important part of interpreting panoramic radiographs. For this, it's important that you have a quiet viewing room and appropriate ambient lighting. That is true for any digital image, in fact. There are certain concepts you need to keep in mind when you're interpreting panoramic images. First of all, the structures are flattened and spread out, like I just showed you in the previous image. And the midline structures may project as single images and double images. So the image of the heart palate, palatine torus, body of the hyoid or epiglottis, all of these are midline structures. So they might get exposed once or twice during the rotation of the image receptor as well as the X-ray machine and end up getting double imaged. So this is what I was talking about as superimpositions, which we will look at in detail when we're looking at the imaging. Also, ghost images are formed. Let's look at this interesting part also a little later on. Soft tissue outlines are seen, air spaces are seen, and relative radiolucencies and radio opacities are seen. All in all, panoramic radiographs are unique. So, there are some tips to look through a panoramic image when you're looking at a flattened out image of your teeth. Number one is to divide this panoramic image into 9 segments for ease of diagnosis and so that you do not miss out any of the findings. And move on from the first part to the second, third, fourth, fifth, which is the area of where the dentition is, sixth, seventh, eighth, and then towards the ninth. So essentially, your eyes are scanning through from one corner of the image to the other corner of the image in a pattern, in a grid pattern where you've divided it into 9 segments. So, if you were to look at the basic anatomy of panoramic images, there are mandibular landmarks, maxillary landmarks, and a lot of other shadows. So, it's important to understand that you already have a basic knowledge of anatomy and then we build on that knowledge. So, I will just pen out few of the most important areas of the landmarks, starting from the corner which I had mentioned. So we'll start off with maxillary landmarks. So this is your zygomatic process. You have the lower border of the eye or the orbit, maxillary sinus here, floor of the maxillary sinus, nasal septum. You have the anterior nasal spine here, intermaxillary suture. Sorry, that went a bit off the midline. You have the hard palate. This is the entire shadow of the hard palate. This way, this is the hard palate. Right, and then you have the maxillary tuberosity region. And yes, that's about most of the important parts that you need to know in the maxillary sinus. Yeah, and these are the lateral walls of the maxillary sinus. And so those are your maxillary landmarks. And if you were to look at, um, let's change the color here, mandibular landmarks. Start off with the condyle, the condylar neck. This is the condylar head of the TMJ. Have the sigmoid notch, and then let's compare it on the other side. You have the coronoid process, right? And this is the external oblique ridge, which is coming all the way here. You have the lingular area of the mandible. The entire mandible canal can be traced out. Um, there you go. And then you have the um, mental foramen. You can see the lingual foramen here, which is quite difficult to see on panoramic radiographs. Yeah, and that's about it. You have beautiful mandibular landmarks. Also, this is called as the gonial angle or the angle of the mandible. Other than that, you have other shadows, like for example, this is the shadow of the ear. You can see the vertebrae very clearly. These are the cervical spine vertebrae. This is your hyoid bone. Right, so there are more shadows that are visible, but these are some of the most important ones. Oh yes, and this is the styloid process. So most of the landmarks that we just covered and I was talking about are here, both maxillary and mandibular. And you need to keep understanding and looking at all panoramic radiographs to understand that all of these anatomical landmarks would be present in any panoramic radiograph, and it's about important that you delineate the difference between the anatomical landmark and the a pathology or a finding. Right. Now, let's look at some of the, in detail, the mandibular structures. This is a picture that I've borrowed from the internet. You're able to see, like we told you, the condyle, the neck, sigmoid notch, coronoid process, a ramus, inferior dental canal, that is your mandibular canal, Okay, angle of the mandible, body of the mandible, mental foramen, symphysis menti, and the external oblique ridge. Coming to the maxilla, there's a lot more complicated overlap and superimposition of a lot of anatomical landmarks here. You can see the pterygopalatine fossa. It's like a teardrop shaped structure here. Pterygoid plates over here. External auditory canal, that is your ear canal. Zygomatic arch, which is shown in yellow. A lateral wall of the maxilla, this entire thing, your maxillary bone. Zygomatic buttress, somewhere here, the dashed line, and inferior wall of the maxilla. I would say this is the maxillary sinus floor as well, and hard palate, and of course the inferior concha, which is inside your nose. Surrounding structures are articular eminence. Yes, of course, this belongs to your maxilla and located in front of your temporomandibular joint. Glenoid fossa, anterior arch of the first cervical vertebra. Styloid process, a body of the dens or the second vertebra, and the hyoid bone. These are some air shadows which you should see, and all of these again superimpose over the panoramic structure. You have soft tissue shadows as well as air shadows. You have the nasal cavity and the nasopharynx here. The nasal cavity superimposing over the entire area. You have the nasopharynx. You have oropharynx way down below, basically your windpipe and your food pipe. You have the glossopharynx, that means the gap between the tongue and your palate, and external auditory canal. You also have soft tissue structure superimposing, like the entire soft palate just behind your hard palate superimposing over the area. Whole of the tongue is also there, but it's just blurred out because I told you we are not covering anything that is not within the focal trough. The pinna of the ear, epiglottis, and posterior pharyngeal wall. So that brings us to the interesting aspect of what are ghost images. Now that we've seen there are multiple soft tissue and other structures which cast shadows, it's important to understand that there are certain shadows which can be cast by the jaws itself because of reciprocal movement and the complex principle of panoramic radiography. Ghosts are also cast by external objects like these earrings, for example, which have been left behind. So you would notice something very interesting about these ghost shadows. Number one is that the ghost image has the same morphology as the real counterpart. It appears higher up, blurred, and more blurred and vertically higher up, and larger and on the opposite side. Remember, the X-ray machine and the receptor are rotating around the patient's head. So when this area has got exposed, it has created a ghost on the opposite side, which is larger, higher up, blurred, and on the opposite side. So that is how the characteristics of ghost images appear. So that's why it's important that patient is advised to take away all jewelry that could obscure the image area, or most important area that has to be seen. That is any necklaces or hairpins, earrings, nose rings, all of these have to be taken off, external jewelry. But if the patient is wearing um, braces, for example, is something you cannot get rid of. And do they cast ghosts? Yes, they do. And what about FPDs? What about implants? Now, implants luckily don't really cast much of a ghost because they're within the bone structure. But FPDs can be nasty and can cause a lot of ghosting. So that is inevitable, and more newer panoramic machines have technology to get rid of the ghosting, but the older ones still do end up casting slight radio opacities which are ghosts and can obscure your area of interest. Now, when I mean obscure your area of interest, is this ghost is exactly superimposing over the apex of your upper left molar, right molar, and hence, a first quadrant, and giving you a blurred area here. So, with the latest advancements in imaging software, panoramic radiographs can be really interesting, and you have various fun tools that can be used. But essentially, for diagnostic purpose, you rarely use most of the tools or all of the tools, but you do use them for patient education. They can be very useful in making the patient understand where the lesion is, or where the pathology is, or which tooth are we going to extract, or what is the measurements of a particular area where the implant is going to be placed. So all in all, the imaging softwares have a very interesting interface, and they allow you to make adjustments to brightness, contrast, etc., as well as viewing it in different measurements and planes, and giving you an ideal method of imaging and a very impressive patient education platform. So you can see that the advantages of panoramic image are there. It has a broad area of coverage, relatively low patient radiation dose. We'll speak more about that. The typical effective dose is 9 to 26 microsieverts, which is almost just equal to that of a chest x-ray. It has convenience, multiple convenience. You can see all the teeth together, and they are generally nowadays easily available in most urban and semi-urban areas, and even rural healthcare setups. It can be of great relevance when the patient has trismus, unable to open the mouth due to trauma or other conditions of the TMJ, and also useful in patient education. When it comes to radiation safety, what do we mean by relatively low patient radiation dose? When we compare it to a full mouth x-rays, for example, 14 to 20 films taken, even let it be even an f-speed film or a PSP, is around 200 microsieverts if you use a round collimator. And when you compare that to one panoramic image, the typical effective dose is just 9 to 26 microsieverts, which in effect is almost equal to a 5-hour airline flight or 2.5 days of equivalent background radiation on Earth. So, if you have understood what is radiation biology and safety, you will understand what this comparison is about. This is equivalent radiation dosaging, and the effective dose is just around 9 to 26 microsieverts. Why is there a range? It depends on machine to machine and the area of exposure. So, what is important to understand is using good clinical judgment and applying evidence based imaging guidelines. So just because we have all of these advantages in panoramic radiography, it doesn't mean we use it routinely to replace the intraoral periapical radiographs. It's important to read through and understand best imaging practices of imaging as well as protection. So, if we were to look at the uses or indications of panoramic radiography, most important ones are bony lesions, unerupted teeth. We use it for assessment of wisdom teeth prior to surgical intervention, grossly neglected mouth to assess periodontal bone support when the pocket depth is greater than 6 mm, orthodontic assessment, very essential tool, fractures of mandible, antral disease, that means diseases of the sinuses, especially the maxillary sinus, the floor, posterior and median walls are clearly visible. Destructive diseases of articular surface of the TMJ when you have to do gross evaluation, and not for minor evaluation or very detailed evaluation, is for gross pathology evaluation, and also for pre-implant planning when you want to assess the vertical alveolar bone height. So let us look at some of the images to understand where and how panoramic image can be useful in diagnosis. So I have used most of the images from our own archive for the education purpose. This is an example of a grossly neglected cavity where you're seeing multiple decayed teeth with multiple periapical pathologies. Okay, most of these teeth are indicated for extraction, and all teeth that are indicated for extraction must be imaged. So in this case, the doctor has chosen to prescribe a panoramic radiograph because there is a wide range of teeth which can be covered, and also gives you an assessment of the bone height so that the patient can then receive a denture afterwards. For periodontitis, like we discussed, in cases where there is severe bone loss, horizontal as well as angular bone loss, it's a very important tool in assessment. So you can assess greater than 6 bone loss, vertical bone loss, and also furcation involvement, which can be clearly seen. Mixed dentition, yes, of course, is of great value in understanding where the location of the unerupted or predecessor teeth are, sorry, the successive teeth are. It also gives you an idea that they could be supernumerary unerupted or unerupted permanent teeth, and helps you analyze what the location of this teeth is. Having said that, children, again, you should be cautious while exposing children to panoramic radiographs. Impacted canines, for example, are seen in this case bilaterally, and they're having a normal follicle. Just to remind you that dental follicle is a space around an unerupted tooth, and this should not be greater than 5 and if it is greater than 5 then it is an indication that it could be having a cyst around it, most likely a dentigerous cyst. It's an important tip when you are looking at an image like this and you are unsure, is to use another view from a different angle. Perhaps already have taken a periapical or an occlusal view, and if you're still in doubt or in suspicion, you could then take a CBCT if the teeth are indicated for surgery. For impacted third molars, this is a really important tool. You can see different cropped images taken from different impacted third molar panoramic radiographs. Mind you, these are cropped images of the panoramic radiograph, and you can see mesioangular, distoangular, horizontal and vertical impressions, and this is a very useful tool in understanding the war lines or the winter lines, which gives you the white, amber and the red line to get you an in-detailed assessment of how difficult the extraction could be. More on impacted teeth. You're looking at an impacted canine here, but what is interesting in this radiograph image is that there's a considerable displacement of the maxillary anterior teeth plate. Close attention there, and you will notice that there's a large radiolucency. So for sure, definitely there is some cyst involved, and this most likely looks like a dentigerous cyst involved with impacted tooth. So differential diagnosis on the radiograph, mind you, this is radiographic differential diagnosis, would be an odontogenic keratocyst, adenomatoid odontogenic tumor, or calcifying odontogenic cyst based on the location and likelihood of the occurrence of the lesion. Implant placement, again, panoramic radiograph acts as a scout image or a preliminary image that you would want to do before placing the implant. There are important tips that you need to know. Screening image prior to planning implant should be a panoramic image. For implant site itself evaluation procedure, the preferred imaging methodology is a CBCT, and for follow-up of the implant, panoramic or periapical radiographs can be taken. Again, we have more imaging of the implant placement, whether the implant has been placed successfully or no. This is to understand how close it is to the maxillary sinus floor, and this implant is doing pretty reasonably well. This is an interesting case of one patient whom I've personally seen, where the patient came back with pain after wearing the dentures for a couple of years. The reason was the ridge had further resorbed and this tooth popped out from nowhere. So this was one decayed and impacted tooth which was buried under the soft tissue, and generally edentullousness happens over a period of time, and probably the patient wasn't radiographed before the denture was placed. And after a couple of years of denture wearing, he realized that he had pain in one particular area. And when imaging was done, you find this impacted tooth there, lying there, which has got decayed because it was already exposed to the oral cavity. Of course, for panoramic radiographs are excellent imaging for patients who have to wear braces, who are indicated for orthodontics and post treatment as well. But sometimes during the treatment, you get unexpected issues like these. For example, this is a case of non-vital 4-1 anterior teeth, which has got non-vital because of probably force during orthodontic treatment. And you can also see that the cystic area has actually caused the drifting of the root of the um, canine. Um, yeah, I think it's a 4-2. Probably I got the tooth number wrong. Yeah, more well-defined radiolucencies. This one is a large radiolucency, and based on the size, you can say that it's nearly 6 times 3 mm in size, 6 times 3 cm in size, sorry, and having a very scalloped appearance with multiple locules, and the borders have actually caused resorption of the adjacent teeth. So this would definitely be an OKC or an aminoblastoma. It's very important to understand how close it is to the mandibular canal, and in this case, certainly the mandibular canal is involved. Radio opacities, moving on to another radiolucency is this particular tooth, which was also in a patient who was getting orthodontic treatment done. You can see that the 7 is also submerged in the oral cavity. We're talking about the 3-7 here, and the radiolucency associated with it, which could be an OKC or an amyloblastoma on the radiograph. So it's impossible for us to very clearly tell whether it's an OKC or an amyloblastoma. Histopathology would have to be done for confirmation. Confused for lesions. That is what I was talking to you about. Air shadows. Well-defined radio opacities like the one seen here looks pretty benign and harmless, and this happens to be an idiopathic osteosclerosis or a dense bone island. There is no treatment indicated for this, and it's just left that way. Diffuse radio opacities can also be seen on panoramic radiographs very clearly, like the one seen in the right side fourth quadrant, where you can see a large diffuse area. The borders are merging with normal bone, but definitely you see that there is change in trabecular pattern. The entire bone appears opacified and ground glass like, and this is either a cemento-ossifying fibroma or fibrous dysplasia of the mandible. Moving on to trauma, panoramic radiographs can be very useful when you're looking at trauma. This is an example of mandibular fracture of the left side angle and subcondylar fractures. The angle fracture is on the right side of the mandible, subcondylar is on the left side. So clinically, if you were to examine this angle fracture, you would be able to palpate a Staph deformity. Trauma cases after management and healing, also panoramic radiographs are taken to understand how well the healing has happened. For example, this is a case where bone plating has been done in multiple areas to hold the jaw together, hold the fractured fragments together, and this patient has healed very well. You can see that the bone has fused and the metal plates will remain there in the patient's bone forever. So, based on all the panoramic radiographs that you have seen, we've got an idea as to how the image can be useful in diagnosis of various conditions. Now, let us look at some common positioning errors. Now, if the patient is placed too forward in the focal trough and the neck is bent, you might get an exaggerated smile line and the gonial angles pop out like this, and this image is not very diagnostic. If your patient is positioned too forward, too posteriorly in the focal trough, you get these flattened out, fattened teeth in the center, and the smile line of the panoramic is just flattened. So again, the central area is blurred because they have gone out of focus and are not in the focal trough. If the jaw is positioned asymmetrically, that means the patient is not center has not been taken, or the patient has done a little bit of movement during the x-ray taking, you will notice that there is specific blurring in one particular area because of patient movement, and also one side of the jaw is appearing wider than the other side. Lead apron artifacts, if the patient has a short neck or hasn't been positioned properly, then you would see that the lead apron, which covers the chest of the patient and the shoulders, actually ends up casting a shadow because it is getting in the way of the x-ray machine and casting a shadow. And it is not supposed to. And this is again a non-diagnostic film which cannot be used, and it has to be repeated. This is again a picture of patient movement. Patient was placed too forward and high, and the chin was not resting on the chin support, and it has ended up cutting off the condyles of the patient. And obviously, this image is non-diagnostic and has to be repeated. It has a heavy shadow of the spine and totally indicative of a non-diagnostic image. Right. Now let's look at some commonly mistaken areas. Is this, for example, looks like a nice panoramic radiograph, but what we see here is a very prominent air shadow, probably blood vessels within the sinus and the nasal region. And for example, this area here pointed out shouldn't be in yellow, shouldn't be mistaken for a radiolucency. And the ones which are pointed out in the pink circles, we are so busy concentrating on the canine that is impacted here, or probably the lateral, I can't make out here right now, the tooth that is impacted here, that you totally forget there is a tooth impacted high up in the maxilla, which could have been totally forgotten. So that is why it's important to pay close attention and spend some time diagnosing a panoramic radiograph. All in all, let's look at the strengths and limitations of panoramic radiographs. First of all, it has a broad area of coverage, low patient radiation dose, again relatively low, ease and convenience of examining the patient, uses in case of trismus, and useful visual aid in patient education and case presentation. Yes, of course. The limitations would be lower resolution than intraoral radiograph, and hence it cannot provide you fine details, so it cannot be used as a radiograph to look at RCTs or caries diagnosis. There is magnification of image and the measurements are not reliable, hence it has to be used, the software has to be used to get the exact measurements. So what we see on the screen is a slightly magnified image of your jaws, probably 1 to 1.8% magnification. There is superimposition of real, double, and ghost images, which we have seen in all of the images that we just examined. And this can be quite difficult to delineate unless you have studied the image thoroughly. And requires accurate patient positioning. We have again seen that due to common errors that can happen if the patient is not positioned carefully within the jaws. Within the machine in the focal trough. So panoramic radiograph may not be a great choice for RCTs detecting proximal caries, midfacial trauma or cervical spine injury, TMJ details, implant surgery, and again, very important to understand that it's important to avoid exposure to the thyroid gland, because the thyroid gland is not getting covered with the panoramic with the lead apron, and hence especially in children you might not want to expose them to panoramic radiographs too often. So some of these can be replaced or done with an intraoral radiograph, and the others you might require a CBCT or a CT scan to visualize the details. So the take-home message is panoramic X-ray is a complex image of jaws with multiple superimposition of structures outside the jaws. Knowledge of basic anatomy is key to better understanding. Systemic and repeated approach to interpretation is recommended, and use best practices in imaging and protection and pay attention to details. So that was about panoramic imaging. If you have any doubts, please feel free to contact me and I would be happy to clarify them to you. Right, a big hello to you, all of you, once again. And now I am going to discuss about extraoral radiography. When we begin, it's important to understand few terms: posterior view, lateral view, axial view, and a sagittal plane. So the posterior or would be X-rays coming from the posterior of the skull towards the anterior. Lateral means X-rays coming from the lateral side of the head. Axial view or axial plane is the plane which is cross-sectional, and this plane in brown here, which is cutting through the axial section. Sagittal would be the yellow one, that is cutting through the skull midway into half. So radiographic baseline would be the cantomeatal line from the outer canthus of the eye to the external auditory meatus. The term parallel and perpendicular will also be used, as well as central beam, which means the center of the source of X-rays from the X-ray machine. So generally, extraoral radiography can either be done in a large radiology setup where the patient is lying down on the radiation table, which is also called as a Bucky table, and the source of imaging, the X-ray source, is from the top, or they could be standing, just like the chest X-ray. In a dental setting, of course, it is different, where the patient is standing in a setup which enables extraoral radiographs, and all the radiographs that I'm going to talk about can be done in the dental setting using the cephalometric section of the imaging machine. So this is the panoramic section or the CBCT section, and this section is the cephalometric section. So there are guide planes or beams which help to stabilize the patient, including the forehead and the external auditory meatus, so that the patient can be stable within the machine while the X-rays are emitted from the same X-ray source. The image receptor would be the sensor, which is located within the X-ray machine itself. Now, conventionally, in older days, there were cassettes similar to this in which you had to place a film. They had intensifying screens with grids, and then you would require a table like I showed you in the previous image, and this cassette assembly would go into a slot which is adjacent to the area where the patient would stand. But now almost all radiology setups have a digital imaging section in which the cephalometric or extraoral radiography can be easily done. So let's look at some of the skull views and cephalometric views. So these are various types of views that can be taken for the skull. They are the lateral skull or lateral cephalometric projection. You have a small variant called as a true lateral skull view also. Then you have the submento vertex or the base view of the skull. You have the Waters view, which is a standard occipitomeatal view or 30 degrees one. This is preferably used for visualizing the paranasal sinuses. You have the PA skull or PSF, which is the posterior anterior view of the skull. You could also have a rotated PSF when you want to see one particular side more clearly than the other. Then you have a reverse down view, which is an open mouth view. I will show you what that is. You also have specific mandibular views where the X-ray or the image receptor is outside the mouth, and you have a ramus view and a body view. Now, these views are more or less obsolete with the panoramic radiograph being able to cover most of the structures that are visible in these views. So let's look what a lateral cephalogram is. This is the most common view that is indicated for orthodontic treatment. The patient is the side of the patient is facing the sensor. The film or the sensor is parallel to the mid sagittal plane of the patient, and the X-rays are perpendicular to the mid sagittal plane. So the X-rays are coming from one side of the head. The patient is facing the sensor. Sorry, the another side is facing the sensor, and X-ray beams are directed perpendicular to the sensor and the mid-sagittal plane of the patient. So what you essentially see is one side of the face of the patient or the jaw of the patient superimposed over the other side. So this is a very good view for assessing the profile of the patient. As you can see, both soft tissue as well as hard tissue structures and of importance in orthodontic treatment planning. Next is the true lateral skull view, where you see the entire skull, also taken in a similar manner as the previous lateral cephalogram. Now these are indicated for fractures of the cranium and cranial base, to see the middle third facial fractures, to investigate frontal, sphenoidal and maxillary sinuses as well, but of course they are superimposed over each other. And to see diseases of the skull. Like for example, you can observe if there are any changes in the skull in Paget's disease, multiple myeloma, hyperparathyroidism, tumors of the sella turcica. I can see the sella turcica quite clearly here. Right, and these, for example, arrow is pointing out towards punched out radiolucencies in the skull, which is more likely to be due to multiple myeloma. Then you have a posterior anterior view where the patient is facing the film or the sensor, and the canthomeatal line is at 10 degrees to the X-ray film and or the sensor, and the patient, the X-rays are coming from behind the skull. So the central beam is again perpendicular to the film or the sensor. So the indications for this would be fractures of the skull vault, mandibular fractures, posterior third of body angle rami or lower condylar neck fractures, because all of these areas can be appreciated beautifully. Conditions affecting the cranium and the intracranial calcifications, mandibular and maxillofacial deformities, tumors, and cysts. So essentially, the posterior part of the skull is superimposing over the anterior part of the skull, and all of these superimposed structures can be visualized in the PA view. The term occipitofrontal is used because the X-rays are traveling from the occipital to the frontal of the skull. Waters view. This is also called as a PNS view, which means paranasal sinus view, and specifically of application in paranasal diagnosis. So you can see that the canthomeatal line is at 37 degrees to the film. The central beam is perpendicular to the film. So the X-rays are still coming from behind the patient, from the occipital area, but the patient's head is tilted upwards so that the canthomeatal line is 37 degrees and the mouth of the patient is open. This is done so that the sphenoidal sinuses can be clearly seen on the superimposing on the palate of the patient. So the indications would be for specifically for viewing the sinuses. You can mainly see in the maxillary sinus very clearly. You can see the frontal ethmoidal sinuses also, as well as sphenoidal sinuses, which superimpose over the palate area. So this view is useful for middle third fractures, Leaford 1, 2 and 3 fractures, zygomatic complex fractures, as you can see the zygoma clearly, nasoethmoidal and orbital blowout fractures, and also coronoid process fractures can be visualized. The submento vertex view. Now this is a little different from the previous views. You will notice that the patient is in the opposite direction. The X-rays are coming from the front of the patient and directed towards the posterior of the skull. So the canthomeatal line is parallel to the film. So now you notice that the patient's head is tilted backwards and the central ray is perpendicular to the sensor or the film. Now the indications for this X-ray would be fracture of the zygomatic arches. So you can see the zygomatic arches very clearly when the lower arch actually superimposes over the upper arch. And this view you should be very careful and not to be, it's not indicated for anyone with cervical condition or a suspected fracture in the neck. So it is indicated for fractures of zygomatic arches. These thin bones are seen with reduced exposure called as a jug handle view. We'll be viewing it in the next slide. Destructive or expansive lesions affecting the palate, pterygoid region and base of the skull, as well as sphenoidal sinuses can be seen. This is the jug handle view where you can see the zygomatic arches like handles of the jug, and when you're expecting a fracture, facial, mid-facial fracture where the person has, for example, got into a fist fight and the zygoma has fractured. So you will see that the fractured zygoma caves in and very clearly visible in this view. Next is reverse town view, probably named after the person who first recommended this view. This is also a posterior anterior view where the person's head is tilted downwards and the canthomeatal line is at 30 degrees to the sensor or the film, and the central beam is coming from the occipital region directed forwards, perpendicular to the sensor. So the indication would be slightly different if it's a Townes view, which is an anterior posterior view, and a reverse Townes view, which is a posterior anterior view. So the reverse Townes view is more commonly used. You can see high fractures of the condylar neck here. The neck of the condyle is very clearly visible on both sides. Intercapsular fractures of the TMJ and condylar hypoplasia and hyperplasia can be visualized. So remember, this is also a PA view, but the patient's oral cavity is open and the head is bent downwards and the canthomeatal line is minus 30 degrees to the film. So this summarizes all the views that we've discussed. The right from the cephalometric view, submental vertex. This is your PNS view. This is a PA view, reverse down view, and these are the mandibular views. Now, most of these X-rays are actually less utilized in a routine dental setting. Reason being that the panoramic and CBCT views or images have actually made these particular images obsolete. But nevertheless, it's important that you understand and remember that these views are also to be used in low resource settings and in settings where a dental radiology setting is unavailable and you only have the medical radiology facility. Then you would want to utilize these views to help you get the area or image the area that specifically that is required to be seen. So this is a summary chart which shows you which view can show you which part of the body. I feel it's a very useful chart and shows you how useful that particular view is for visualizing a particular area. For example, if you were to look at the body of the mandible, then the lateral ceph and submental cortex have low usefulness, whereas a PA view and oblique body of the mandible or a panoramic have medium to high usefulness. So that is to summarize all the extraoral views that are present. And these are my references. And thank you very much.